we talked all things ACL or anterior cruciate ligament. We talked about what it is, what its purpose is in the knee. We also talked about how you go about injuring an ACL when it comes to contact or non-contact types of injuries. We also talked about what sports have the highest rates of ACL tears. We talked about different forms of ACL prevention programs and which muscle groups should be focused on. We also talked about what surgery for an ACL reconstruction looks like. What are the different graft options that surgeons have to choose between? What are the things that we see before surgery that lead to the best outcomes after surgery? What does early rehab look like versus late rehab? And most importantly, it was just a really good conversation between a physical therapist and an orthopedic surgeon. When we get the two professionals to team up, we can give our patients the best possible care. You guys are going to love this.
The Prehab audio experience will teach you how to take control of your health through knowledge by optimizing performance, promoting longevity, and keeping your movement system in tune. Welcome to your host, the Prehab Guys.
All right, guys. So we are going to be covering all things ACL related. We have an orthopedic surgeon here, Dr. Nima Mehran, who's going to be able to answer all your guys' questions for the most part. He's going to take the lead on this one. I'll talk about anything rehab that comes in, but for the most part, all the surgical stuff, that'll be you. Let's begin. So what is the ACL?
So I got my trusty knee here again. Hopefully this works.
There we go.
Okay, so the ACL is the ligament that attaches the lateral, so the outside of the bone, you can see it here, the outside of the thigh bone to the inside of the tibia bone. And you can see this ligament going all the way across right here. Now that ligament is made up of type 1 collagen, and it's responsible for anterior translation mostly. So it's responsible for preventing anterior translation. So preventing this function right here. So you can see the ACL stops it. You can see the strain on it. And it's also responsible for varus valgus, which is moving away side to side, and rotation. So the ACL, it protects the knee from all those motions. And when it's torn, now when you're playing sports such as basketball or soccer or football, any type of cutting or pivoting sport, the knee is vulnerable. Once the ACL is torn, the knee can now rotate on itself. It can kind of collapse and it feels unstable. And as a result, you can now risk damaging your cartilage and your meniscus, which are much more difficult to repair.
Awesome. When people tear their ACLs and you see them in the clinic, what's that decision-making process for you in management? Where are they going to go? Are they going to go PT? Are they going to get it repaired or reconstructed? And I guess talk a little bit about that.
Yeah. So nowadays, everyone knows so much about the ACL that it's become kind of a seamless process. And what happens is they usually see their primary care doctor or a therapist or someone that they see before us. And that person's like, hey, your knee feels a little bit funny. You're having these instability episodes. The knee's usually swollen. So how do they present? They present with complaining of instability after a non-contact injury, most commonly, but it could also be contact. The knee swells up pretty quickly, usually the same day, sometimes the next day. And it's the reason of that for the knee swelling is because the artery that feeds the ACL tears. So it forms what's called the hemarthrosis, meaning the blood fills the knee. Now, the patient then goes and sees the first line doctor or therapist or sometimes chiropractor. And that person says, the knee seems funny. They do a Lockman test, which is, when you're doing that pull to see if there's any translation or pivot shift. And if they feel like there's some laxity there and looseness, they send them for an MRI or to see us. At that point, when the patient comes in, we usually already have the MRI. The work's pretty much done. We go through the same physical exam findings. We want to find out how they injured it, whether it was a contact or non-contact, to continue learning about the mechanism of injury. But really, at this point, it becomes more, what do we do to treat it? Mm-hmm. So generally, if there's a partial ACL tear, it can be healed with just some physical therapy because they have that knee stability still. I find that partial tears that have a true pivot shift, that rotational instability, after a few months of like therapy, tend to go on to needing surgery. But if they don't have the rotational instability, oftentimes they do fine without surgery. Now, the majority of what we see are the full tears. Now, that tear happens to be often, in the midline of that ACL ligament. When that happens, we need to usually reconstruct the ACL. It's not a candidate for a repair. So the majority of the conversation, our first conversation, is discussing what type of graft a patient wants to have if they decide to have ACL surgery. So what I do first with the patient is the first step is, are they a candidate? Do they actually need a reconstruction? So who needs a reconstruction, right? The people that need a reconstruction are definitely young athletes who are playing cutting and pivoting sports. That's a no-brainer. Because if they go on to play soccer or basketball or rugby or any of these cutting or pivoting sports, lacrosse, stop-and-go sports, they're going to twist that knee again. They'll twist it without the ACL, and you can see it here. And they start twisting it, and they're damaging cartilage and tearing meniscus. And sometimes that process, that could be irreversible. We might not be able to repair really bad cartilage injuries or meniscus tears. So we want to protect them from that. So in those patients, it's a no-brainer. We start talking about ACL reconstruction. However, there are patients who are older. They're in their 40s and 50s, and they have a lower activity level. They may only want to jog or, get on a bike or exercise or, go to the gym and work out and just lift some weights. Oftentimes, they don't really need an ACL surgery because you can still jog without an ACL. You can row without an ACL. You can bike without an ACL. You can do squats without an ACL, but you can't cut or pivot without one. So the first thing is deciding if they really need it. And age should never be a factor. I took care of a 55-year-old martial artist who had zero arthritis and was still beating 25-year-olds in competitions. She needed an ACL reconstruction. Yeah. It's not age, it's more their activity level, right? Tom Brady tears his ACL. He obviously needs an ACL reconstruction. He's playing high-level sports, despite, doesn't matter that he's 40. So that's the kind of thought process first to decide whether or not if they're a candidate. Then we get into the big discussion that people always want to ask about, right? Graft choices. So the way I break it down is if they're over 40, right? There are some studies that have shown that patients who are over 40 years old can have a success rate with a low rupture rate of their graft, whether they have an allograft, or an allograft meaning using somebody else's tissue, or an autograft using their own tissue. So over 40, that's a good patient population to consider using somebody else's tissue, because you don't want to have to take good tissue of theirs and, rob Peter to pay Paul, right? We don't want to take a week in an area if we don't have to, if the results are similar. Now, if they're someone that's a high-level athlete and they're over 40, they're playing pro sports, semi-pro sports, I still want to use their own tissue. But in general, most recreational athletes over 40 using their own tissue, using someone else's tissue is a very good option because they generally have low rupture rates and low failure rates.
And so why do you prefer taking that tissue then, like you said, for the younger population? Go for it.
But for the younger population, there's a study that came out. There's a Moon Network, and it's a network, a multi-center network that was created, I believe, out of Vanderbilt, if I'm not incorrect. Vanderbilt, WashU, a few hospitals. And the surgeons who did that, they showed that basically if you use an allograft and under the age of 25, and especially under the age of 20, there's a 4 to 5 times higher rate of rupture. Patients under the age of 19 and 20 have a much higher risk of failure. So you definitely don't want to be putting in allografts at this day and age in that younger population. Now, revision may be a different story. That could be a totally different story. But for a person who a first-time ACL tear, who's 19, 20, early 20s, playing high school, college sports, it's kind of a no-brainer. You want to do an autograft using their own tissue. The gray zone comes in the early 30s, mid 30s. And, that's kind of the patient population where you say, hey, well, what are your levels of activity? Are you a recreational athlete who's not really playing cutting and pivoting sports that often? And they could consider an allograft. But if you're ever in any doubt at an age group in the early 30s or mid 30s, for me, the better option is just choosing autograft if you have any doubt whatsoever.
Yeah. I think going back on that too, I think the big point is figuring out what the patient's goals are. Like you said, that's like step number one. I think because of how much ACL is talked about just in general media, everyone thinks, oh, tore my ACL, I have to get surgery. But you can run, you can squat, you can go to the gym, you can do so many things. Or maybe you just make those modifications. Maybe I don't have to play tennis, once every 2 months. I'll just give that up. And now I'm not playing cutting sports anymore. You don't necessarily have to go through that 9-month, 12-month process. It's a big rehab process if you go through that reconstruction.
Yeah, Mike, you nailed that. I really try to explain that to people, especially because I have some patients who are in their 40s that choose to undergo a reconstruction because they think they want to play recreational soccer once every couple of weeks with their buddies. And a lot of those patients end up not going back because of fear of re-injury. Mm-hmm. So you have to be completely invested in the process and the procedure and the recovery.
Oh yeah. Okay. So let's go on now. Cervical. So say someone has chosen, they are a good candidate, and say you've decided to do an autograft, which you said is using the person's own tissue. Mm-hmm. Now there's a lot of different options for you. Can you go ahead and explain what some of those different options are and how you weigh maybe one versus the other for that patient?
Great question. And I honestly spend, I would say, if I have a 30 to 40 minute consultation with someone, I would say the majority of my time is talking about the risks of surgery and which autograft. So again, using this model, so here your knee here, you can see I kind of draw it in because I tell my patients all the time. But over here, that's a quad tendon autograft. You take it from the middle of the quad, partial thickness. And then over here, you have the patellar tendon autograft. And with the patellar tendon, I usually take bone on each end. I take bone from the patella and bone from the shin bone, the tibia. And then finally, which isn't on this model, but coming on the medial side, the hamstrings attach around here, and you can take the hamstrings. So going over each one, the patellar tendon autograft is kind of become our gold standard. If you do there's a couple survey studies that have been done on a lot of the higher level athlete physicians. So physicians that are taking care of professional basketball, football players, and they tend to do patellar tendon autograft, 80% or more. The reason I think that most doctors in a young population, high school, college, pro level, like the patellar tendon autograft is because of the bone on both ends, right? Because when you imagine if you're drilling a hole, to put a new graft into the thigh bone here, and you're drilling a hole here, and you're filling that hole with bone on each end, it has a faster incorporation rate. Bone is healing to bone. So it's a little bit stronger. And in addition to that, we use screws on the bone to make an interference fix. So the fixation is stronger. So a lot of people really like that construct. Now, patellar tendon having the bone on each end is really nice, but there's a lot of drawbacks. One of the most common drawbacks, as you know, because you deal with patients with this all the time, is the anterior knee pain. So imagine you're taking this tendon right here, and that's exactly where people kneel. And that's where their scar tends to be. So there's a good percent of patients. Yeah.
We have our kneecap here. I don't know how much you guys can see. They're going to take
a little bit higher. Yeah.
Right through here. That's where we're talking about.
So a patient kneels on that area, and there's studies that show 20 to 40% of patients, they complain of that anterior knee pain or kneeling pain, and it can bug them. So it's something to consider in patients who maybe have a career choice, maybe patients who are working on their knees, people who are in plumbing, construction, like that, or laborers, or for example, sometimes patients who are, Muslim that pray several times a day and they're on their knees a lot. They may not like the idea of any type of tendon that you take that can cause them to have anterior knee pain. So it's something to really discuss with the patients. Additionally, taking the bone from the kneecap has shown in some studies that kneecap is more vulnerable, and you can have a patella fracture. The kneecap can actually break if they fall on it.
Yeah.
And that can be a really tragic situation where, fixing one of those after that can lead to a lot of complications from that surgery, as well as the patellar tendon can rupture. So those are some of the risks of a patellar tendon. Now, I love it. It's a great option, and I love to use it for my patients who are in their, late teens, early 20s, high-level athletes, high school, college pros. It's my go-to for that because of the fixation and because of the bone on both sides. But it's not for everyone, right? Now, there's another good option, the quad tendon. The quad tendon is more, the last 15, 20 years, the data has been coming out on it. It's kind of becoming more and more prevalent throughout the country. But there's a lot of people who still don't use it. And so as a result, many patients may see a doctor who doesn't really discuss it. But I find the quad to be an excellent option. One of the reasons I like the quad is because it's it's the thickest one out of all three tendons. It's the circumference of the quad, and the percent of collagen it's so much thicker and higher. The percent of collagen is higher. So I love the quad. It's a reliable 8 to 9 millimeters, and that's what we like to see when we're reconstructing the ACL. So the quad, what are the risks, or what are the upsides of quad? The upside is you don't have that anterior knee pain that you get with patella. But with quad and patella, you do have a decreased quad strength. 10 to 20% of patient, or 10 to 20% less strength in your quads as you're extending the knee with both of those grafts, patella and quad tendon, because they're affecting your extensor mechanism, which is the ability to extend your knee. So I love the quad because of the thickness. It's good for revisions. It has less anterior knee pain. But what are the dangers of quad? People can rupture their quad. They have that weakness of the quad, like the patellar tendon, as we mentioned. And some people can even get a Popeye muscle. I've actually never seen one, but it's kind of like the biceps. The muscle can pop up from where you take the quad tendon. That could be a cosmetic deformity, can bother people a little bit. Now, in terms of, one other thing to mention is the quad, one side of the quad, you can actually take a little piece of bone too. So you can have bone on one end of the quad. I choose not to take it. I like to use my quad as my soft tissue graft, like compared to a hamstring. Sometimes in bigger people, I find it more reliable than a hamstring, because the hamstrings can be really thin and the circumference isn't as reliable as the quad. So I like to compare that more with my hamstring. Something to keep in mind is a lot of patients who are tearing their ACL, they're quad dominant, right? Their quad strength is so much greater than their hamstring strength. And what is that doing? That's pulling the shin bone forward, putting you at risk for an ACL tear. So it's one of the benefits of these patients of taking one of the extensor tendons, whether your quad or your patellar tendon, is you're decreasing a little bit of that strength, and that could even up that ratio. So it is actually a benefit in a sense. And now the hamstring, right? So the hamstring is a secondary stabilizer of the ACL. It starts from your butt on the backside and comes all the way down and attaches to the front. So the hamstring actually decreases your anterior translation as well. So sometimes taking that can put people who have a higher quad to hamstring strength ratio at a little bit more risk. High. What's a good example is like fast runners who are changing direction. Soccer players, like these sprinters. You can put them a little bit greater risk. But the hamstring, in Europe, they've been using that for 50, 60 years with great results. Very similar to quad and patellar tendon. So it's a great option. It's a smaller incision for people that are worried about cosmetic deformities. Mm-hmm. For girls who are smaller, who are worried about like cosmetics, and they want a nice, strong ACL option, but they don't want a big gash in front of their knee, and they don't want that anterior knee pain. It's a great option, and it's you can get the size that can match their body size. For bigger guys, sometimes the quad's better because of the thickness and the girth of the quad. But hamstring, you don't get the anterior knee pain. And one of the things you do get with hamstring and a little bit with quad, a little bit less because it's not as lax of a tendon, is you can get loosening over time. It stretches a little bit. You don't get that as much with a patellar tendon because it's a fixed length and there's bone on each end. But that's also, patellar tendon tends to be the hardest surgery because it's a fixed length. And when you drill your tunnels and you're trying to find that perfect ACL graft length, you can't change that length, but you can take more quad, and you can fold your hamstring over in a different amount of times to create more or less length. So those are some of the things to think about. Hopefully I got everything there.
Yeah. I didn't realize that people were taking, or like you were taking quad tendons and not taking part of the bone plug. So it basically is a soft tissue graft, kind of like your hamstring. Are there studies comparing the two of those?
Yeah, there are. So the truth is, if you look at studies over the last 20 years, the majority of studies show that all three of these have great outcomes. Like I said, in Europe, they do more hamstring. In the United States, we're doing more patellar tendon, but all three have great, and we're doing more quad now. All three have great outcomes. Generally, the range of failure of the graft is anywhere between, as low as 2 to 3% to as high as 8 or 10%. For these three grafts. There have been a couple of recent studies that have shown that hamstring may have a slightly higher rupture rate compared to patellar tendon and quad in some of these multi-center studies. So that's something to keep in mind. but overall they all have great results, you know?
Yeah. It's a solid surgery. But that needs solid rehab. And I guess we'll start going into some of these questions that we have right now. This is from Nooster 13. What's your typical post-op ACL rehab protocol? I know for me, the first thing I want to do is manage swelling. Even before that is educate. Probably the first 2-3 sessions, I'm not even doing too much with the patient. I'm just talking to them and educating. Yeah, I might be doing stuff while I'm talking to them, but it's all education in those first couple visits. I want to decrease swelling. I want to get full knee extension by 2 weeks. I want to get their equivalent degree of hyper knee extension too within 2-3 months, ideally on the 2-month side. Full flexion by about 6 weeks, 8 weeks, and range of motion is key. And then after that, it's strengthening. You have to get that knee brutally strong. And then only when it's brutally strong can you then start working on recovering and pivoting into plyometrics.
Absolutely.
People need to know going into it, it is a long process.
Yeah.
You have to love working out, or better come to love working out, because that's basically what your rehab is going to look like towards the later stages. You're going to be doing legs 3 days a week, and you're going to be pumping heavy iron, and you're going to be sore all over, and that's just part of the process.
Yeah. And so you nailed that, Mike. And you nailed that whole thing about extension. Extension's the most important thing. You lose a couple degrees of extension, it can really affect your life. You have a limp, it can lead to lower back pain. You don't feel right walking. You lose 10 degrees of flexion. You may not even notice it in your functional outcome. But what I do, so usually what happens with most patients is the patellar tendon patients tend to be in a little bit more pain than the quad or the hamstring. Yeah. So they're a little bit slower off the gates. Wouldn't you agree?
Yeah, it's the couple of the quad tendons that we're seeing too. They seem to be, I don't know why their quad lag is more than some of. I don't know if that's just me seeing it in comparison to the patellar tendons.
Yeah.
But I see that their quad lag lasts a little bit longer. So.
Interesting. So yeah, I haven't been noticing too much with my patient population at least, but it definitely could be there. But one of the things, so what I do is after I put them in a brace, and I usually tell them to be in that brace for 4 weeks. The first reason they're in that brace is one, because they get a block for pain control and they don't have good quad function. So I want the braces that'll protect them. I keep them in extension. That's the second reason, because extension is the hardest thing to get back. I like to lock them in extension to make sure that they're 100% going to get that extension back. And then, we work on that range of motion that first week. Like you said, it's all about, crawling before you walk, before you run. So, right, I want them to get that range of motion back. Most of them usually, try to get it back by about 6 weeks, like you mentioned. There's a few patients who can lag and take up to 3 months. Everybody's recovery is different. Everybody's surgery is different. Did they have meniscus repairs? Yep. Did they have cartilage, issues? Did they have an osteotomy done? Did somebody have to cut the bone to change their slope and things like that? Everybody's surgery is different. And now, so when they regain motion, usually 3 to 6 months, starting to jog, really get on that strength program. And then it's 6-month lateral movements, jumping, and doing more of the sport-specific type stuff. And my goal is return to play around 9 months.
Yeah.
But again, I never base it on time. When a patient comes to me, and we could talk about this because I know you and I are probably similar, I have you guys do send me some information. From you, I want hop testing. All the 3 different hop testings. And then I want quad strength, all compared to the opposite leg. And ideally, I want to see that greater than 90% of the opposite leg before I clear them back to sports. That's usually the 9 to 10 month range. And in my clinic, I make them do a single leg squat. And when they do that single leg squat and they're going up and down that single leg, I'm looking to make sure their pelvis is stable, their femur, their thigh bone is not going in towards the midline of their body and not rotating in, and their knees not dropping in, And if they have all that straight up and down, those are all good signs for me. What do you think?
Yeah, no, 100% on board. And I even say, so we have a handheld dynamometer now at the clinic. It's awesome. I use it on everyone. Because before, you're just guessing on how you never know how strong someone is. You're just saying, oh, they feel strong, or oh, it feels weaker than the other side, but you don't have anything objective. With the handheld dynamometer, I now know. I know a lot of the studies have a 90% LSI for quads, but there's a couple other guys that want it to be like 110, 120, and I think I'm more on board with that. So they want it to be stronger because you're comparing it to the other side that it has been now 9 months. They haven't been working out as hard on that leg either.
Yeah.
Where they were on their baseline, they're probably at a lower point than when they were when they first injured it. So let's get it even higher than that.
Yeah.
Which is where I've been going for quad strength. And then the hop tests are good. I think the hop tests are a good starting point, but and it's weird. It is something objective. It's something that we can use to compare between patient A and patient B. But in the clinic with everything that you've done to them, whether they're ready, because I've exposed them to 1,000 times more than what that one hop test or even 5 hop tests can do.
Yeah.
You'll know. And a big thing too, I think you forget, is the mental side of it. They have to feel confident. There's a lot of questionnaires that we can give patients now. Are they mentally confident, and are they capable? Do they think they can go back? That's probably the hardest thing for a lot of patients to get.
Yeah, actually, it's really interesting. I'm glad you brought that up. So one of the things I've noticed is, as therapists, as athletic trainers, as orthopedic surgeons or primary care docs, whatever group you're in, I've noticed that we do a really good job now of educating. We're doing a really good job of recovery and therapy, of watching over our student athletes and our athletes, and a good job of surgery. The success rates are all high.
Mm-hmm.
But the psychological aspect, I cannot tell you the number of my patients that psychologically are not ready for this surgery, and the toll it takes on them, and that fear of re-injury. The percentages of how high it is of the patients who do not return. One of the highest reasons for not returning after you're completely past every test is the fear of re-injury. And I wish that's the one thing, we want to do a better job of. And I think that, sports psychiatrists and psychologists can play a major role and help our athletes in that.
Oh yeah. I think it's, it needs to be. I wish we had someone like that. I know within PT, because we do get to spend a lot of time with people. A lot of people in our field are going. Pain science is one whole part of it, but the whole therapist side. We're a physical therapist. The physical side, we're getting really good at getting people strong. Which hopefully people are getting really good at getting people strong, getting really good at teaching people how to move. But we're forgetting the therapist side of it, the mental side. So key, making sure people are confident.
Absolutely.
For any injury, but especially this one where they had a traumatic injury. They spent 9 months minimum working their butts off, and then now mentally, they need to be mentally there and ready to go too.
So my quick shout out to Nick Physio, because I totally agree with him, and we forgot to mention this, is the hip and the glute strengthening, and concentrating on that hip rotation and the range of motion and the glute strengthening as well for the recovery and their prehab.
Yeah, the hip strength is huge. I mean, that we know that's part of the mechanism of injury for the ACL. I think a lot of times in rehab sometimes we go too far away from the knee, and we're just with hips sexy, the glutes are sexy, but we forget skills in the knee, we need the quads. So
of course.
100%.
And the hamstrings.
Yeah. 100%. Super, super important. A couple other questions I got from here up that I'm scrolling over to. Did some surgeons are using the contralateral extremity for the graft? I haven't seen that. Have you seen that?
Yeah. There's a few surgeons who definitely do that. There's one surgeon out of Indiana who does that often, has excellent results. It's a really, really good option. It depends on your thought process. I like to, my whole thought process is keep the injured leg and stick with the injured leg because it's already having issues, and leave the whole leg whole. Now, for revisions though, that's the time when I start looking at that contralateral leg, right? I don't want to retake a patellar tendon. But let's say, for example, I have a 20-year-old college running back, right? And he had an ACL surgery somewhere else. 2 years out, he tore it with a contact injury, bad luck. Well, I'd like to use another patellar tendon for him to get that screw fixation in those bones, as long as he doesn't have, the bone loss, assuming he doesn't have bone loss. So it'd be nice to take his contralateral patellar tendon.
Makes sense. I like that. Another question up here from Sports Anatomy. What point do you start pivoting and sideways movements? What signs should you look for? I know for me, when it comes to all the clearances, every surgeon has different time points for the most part. So I know I use that. Huh?
I said, yeah, we're divas. We're difficult.
I use that as my ultimate. I'm not clearing you to do anything until your surgeon clears you. But just because your surgeon clears you to do cutting doesn't mean that I think you're ready for it. So I'll always be at the point or later. I'm never going to be before that point. And you have to know where everyone, fits in. For most people, though, it's going to be after they run, which is a variable time too. So we'll call it 6 months, but that doesn't mean you're doing a lot of pre-cutting. There's so many things that you can do before full-on 100% cutting to get people up to cutting, if that makes sense. But when do you usually start? I guess just from a time. Again, like we said, there's so much more that goes into time-based. But when do you start pivoting and cutting and sideways movements?
Oh, yeah. Sorry, Mike, you cut out for a second. My phone rang. So what I actually, just to reiterate what you said, I couldn't agree with you more. This is a team approach. I talk to my therapist. I look at all their notes. it's really important to me for us to be on the same page. And not everyone's the same. Some are like we said, 12 months, some, are 9 months. But generally for me, the lateral movements, I think around 6 months, most patients are pretty comfortable. And the true cutting and this is usually closer to 9 months for a lot of patients.
Yeah.
Like cutting, actually, I rephrase that, cutting at high velocity.
Cutting at high velocity, yeah.
Yeah, because cutting at lower velocities.
Reacting to things is so much different than just saying, here's a cone here, turn left, cone here, turn right.
Exactly.
They're able to plan that route. It's much different when you have to react.
At 6 months, there's a lot of people who can do the 50 to 75% cutting and motion and the lateral movements very easily.
Yeah. We had a question here from John Yu. What is the ideal quad to ham ratio for men and women? That's not really great. Well, for ACL, I guess. We'll change the question. Thoughts on that? Ideal quad to ham ratio?
I don't know personally. I don't know if there's a number out there. I think the more important thing is you want, in my mind, I would want the quads and the hamstrings to be equal, right? So if one's pulling, the other one's pulling in the other direction. You want them to both be strong. And the truth is, in our culture, we pay a lot of attention to quads, and we generally, growing up, do a poor job of concentrating on the hamstrings.
Yep. Whole posterior chain, I would say.
Yeah, whole posterior.
Very quad dominant, yeah. Nick Physio said, what's more important, extensor lag or eccentric hamstring control? I'm not sure what phase he's referring to or anything like that, but the extensor lag is going to be something that we care about, and we care about really early on.
Mm-hmm.
Correct?
Mm-hmm, absolutely.
But I don't know if this is my leg, this is my hip, this is my knee, this is my ankle. If I'm moving it up, I need to be able to tighten up my quad and lift in a straight line. There can't be a time when I tighten, I try to lift, and then you see the tibia come up later. So that's essentially the extensor lag.
Yeah.
It's a sign of how well our neuromotor control of what our quad is doing. And that's something you're going to probably look at in your first post-op visits, I assume.
Absolutely.
Going on, Craig asked, how many patients are you seeing in the clinic that only heard a pop without any swelling, instability, or significant pain for a short period of time? He said 4 this year.
Yeah, that's a really, really good question. I would say I probably see a couple a month that'll tell me how they really didn't have a really big injury, this really big moment, or, they may have heard a pop, but they didn't have swelling, and it was a very low energy motion. And they end up having an ACL tear. So that's a great example of how we have our history and we have our physical, and you got to look at every detail to figure out whether or not someone truly has something. And if you're in doubt, that's why you have your imaging.
Yep. I know I've only seen one like that. Really unfortunate. He's getting stuff, luggage out of the airplane, and the knee buckled. No real swelling, but it's like it doesn't feel right, and then ACL's torn. I got a question here.
I saw some stuff about like the box jumps and the plyometrics, and I think we should really briefly at least discuss because a lot of people want to know, how do you prevent ACL tears? Obviously, we can't limit contact ACL tears. You can't predict someone taking out your knee. That's hard to do. But for the non-contact injuries, especially working with guys like you can do a good job of decreasing the risk. And one of the ways of doing that are, neuromuscular strengthening, things like plyometrics, jump landing, making sure when you're landing, your knees are not touching, you're not in valgus with knock knees, and you're landing kind of straight up and down. You have better mechanics, and to concentrate on strengthening your hamstrings as well, like we discussed. Those are 2 of the things that you can do to decrease your risk of ACL tears that you can decrease. Now, there are anatomical factors that you cannot change. Why do women have a higher risk of ACL tears than men? One, they're quad dominant, like we mentioned, and they have more poor landing mechanics in general with the neuromuscular control, which puts them at greater risk. But they also have a wider pelvis. They have an increased Q angle, which you know what that is. For the lay people, it's kind of that knock knee. It's more similar to knock knee. They have increased valgus, again, that knock knee, and they have increased pronation at times. So those are kind of things that can predispose us anatomy-wise, as well as neuromuscular factors that can predispose us.
A lot of really, really good injury prevention, injury risk reduction studies for ACLs, especially in the younger demographic in the women. And again, it's like what you said. Yes, there's a strengthening component to it, but it's a lot of movement. Just teaching people how to cut, teaching people how to land from jumps, really teaching that from a young age. I think for all the other PTs out here, all the coaches, all the sports coaches, any performance coaches, if you can implement 20 minutes a day, once a week in the preseason, into teaching your younger athletes just how to jump, how to cut, how to move, you're going to do not just decrease ACL injuries, you're going to decrease the risk of a ton of other injuries, just teaching people a little proper movement mechanics. So it's really, really important to do in our younger athletes.
Yeah, especially in those that soccer player population, the female soccer player population.
Oh, yeah. Question here from John Yu. How early in ACL rehab should hip and glute activation be implemented? I usually start that day one, maybe day two. My priority is on the education really early on and just getting the quad going. But while the quad is there, you can start working on the hip as long as you have time and glute activation. You should start that as soon as you can. Got a question from Mike Sims, 21. After 6 months, how do you monitor – oh, this is what you're talking about. Monitor plyometric jumping with an ACL athlete, box jump, step jump, single leg hops, crossover hop test, etc. You want to integrate – I think we want to eventually do an article on plyometrics, but the way I like to divide it is I divide them into 3 planes. So I go frontal, sagittal, transverse. I'm going to go into my sagittal plane first, so all my forward and backwards hops. Then I'm going to work into the frontal plane side to side, and then I'm going to work into rotational hops. And then from there, you can go double leg to double leg, which is going to be called a jump. So that's going on 2 legs. Then you have bounds, which is going from the left leg to the right leg to the left leg. And then you have hops, which is on 1 leg, landing on the same leg. Using those progressions. And then you can add boxes. You can add depths. There are so many, I guess, fundamental, what do I want to call it, approaches that you can do. And you can apply that. And you can take jumping from, like I said, just starting up your hands in the air on your tiptoes, going down all the way to doing the most complex things. And it only gets as creative as you want to make it, but you have to implement biometrics with your patients. That's where the risk reduction is going to happen. And that's where you're going to build up the confidence. If you give them, and again, don't just be crazy to be crazy and you work your way up to it, but if you're giving them ridiculous, super advanced stuff in the clinic and they're doing it while responding, their eyes closed, yada, 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 they're going to have confidence to go do that cut on the field. If you're able to, give them that stuff in the clinic and expose them to as many different variables as you can, that's how I think you can increase their confidence better, by exposing them to more stimuli in the clinic.
Actually, and to piggyback off your confidence point, it made me think of something. One of the things that we're finding in some studies, and actually anecdotally when you talk to patients, people who are failing their ACL reconstruction and their graft fails, besides the ones that are going back to earlier for other reasons, contact, etc., there's a fatigue component. We're finding patients who are not properly have not properly done enough endurance training. They're going back and they're fatiguing, and so there's more stress going through the ligament as their muscles are not compensating because they're fatigued and they're having re-ruptures. So we really want to concentrate on that endurance training near the tail end of their recovery program. Oh
yeah. There's a question from Emily. It says, what do you like to focus on patient education on? I guess you can start with that. What do you like to focus on? Someone, is going, let's even start pre-op. They're going in for it. You've already talked about a lot of the education on graft options and choosing, is it right for you? But now that you've determined it's right for you, what do you like to focus on for the education?
So my number one thing with education is extension. I just drive that home because I do not want to see someone be 3, 4, 5 degrees shy of extension, have a little bit of a limp, have an abnormal gait, so walking abnormally, develop low back pain over time, have these issues. I never want to see that. Because that's preventable. We can't, as a common quote is, worry about what you can control, not what you can't control. Yeah. I can't control someone taking somebody out on a field, but I can control, my ability to tell someone about the importance of that extension. And if I don't, I feel like I failed them. So it's super important to me to really spend a lot of time talking about extension. That's my number one thing. Then after that, it's get your range of motion back, as we talked about. And then it's really, really, really work on strength. And then my final point is, no matter what I tell you, no matter what your therapist, your athletic trainer, or your coach tells you, you never go back until you feel right. Because if you don't feel right physically or mentally, either or both, you shouldn't go back, because you're putting yourself at a risk that you don't need to put yourself in.
100%. Not even going to change anything. That's so true. Both of those things. I know with the extension, I harp on that from day one. I don't think people realize how long they have to sit with their legs straight when they're not doing anything, and how easy it is to watch TV and work on your extension at the same time. It's like, I'm not asking you to go run a marathon. You just sit there with your heel propped up and work on your dang extension.
Yeah, it's so true.
All right, this is a question from Napster 13. How does your rehab protocol change with the meniscal repair or MCL injury?
Oh, great question. So generally for me, I try, most MCLs, they heal non-operatively. So I really try to give someone 4 to 6 weeks to heal that MCL before I take them into surgery for the ACL. Usually that heals, and so it's not too much of an issue. Now, the meniscus repair is a great question. So generally in that situation, if I have a meniscus repair in the back, so let me grab my knee model, going over here again, in the posterior horn, meaning if this is the front of the knee, over here in the back of the knee, at this area, the back of the C, if that's there, where most of the meniscus tears are, and I repair that, we kind of talked about this in our meniscus video, but it's very similar to a regular meniscus repair. I limit them from 0 to 90 degrees in the first 4 weeks. So I want their motion to go to 0 or hyperextension, whatever their original extension was, all the way to 90 degrees, a perfect L. And after that, I don't want them to go past that because I don't want them to stress that repair. Additionally, I limit squats. So squats less than 60 degrees of flexion for the first 3 to 4 months, because again, they can stress that repair. So it's okay for them after 4 weeks to work on full motion. I just don't want them to get up from a chair and go, doing squats from in and out of a chair. I don't like the idea of that.
Cool. There's a question here from Dr.
So people know, when we repair a meniscus and we do an ACL reconstruction, the success rate is much higher because of that bleeding from the ACL reconstruction can really help improve the meniscus.
Yeah. Interesting. There's a question from Dr. Nirja. Is there any relationship on type of graft and early onset arthritis? Oh.
Great question. So there's the evidence about that. There's some evidence that shows not early on, but over time, that patellar tendon autografts may increase your risk of osteoarthritis compared to a hamstring, for example.
This is osteoarthritis within the knee joint, not the patellofemoral joint.
Yeah,
okay.
Both. Yeah.
Okay.
Yeah. So additionally,
okay. No, go for it.
I was gonna say, it made me realize, I don't know if I mentioned this when we talked about graft choices. The major pros of patellar tendon, because of those 2 bone pieces, or if you use one of the bone pieces on a quad, is when you're using bone in those tunnels, instead of just soft tissue, you have a faster incorporation rate. Now, faster incorporation rate does not equal graft maturity. That takes time. It means that the ends may have healed faster, but the ligament still isn't yours. It hasn't matured to be your own native ligament.
This is just something that came up to me. Have you ever seen a graft? I mean, early on in those first 3 months, when people have injuries when they're going through the rehab, are the grafts tearing or are they just coming loose from the fixation? Does that make sense?
Oh, yeah, that's a very good question. So usually early on, it's not because of a graft rupture. It's because of some kind of fixation failure. So
is it an easier fix then, or you have to go through the whole process again?
That's a really good question. I haven't had too many early on failures, but if that happens, I mean, you got to go in and see if that graft that you put in, if it's early enough, if you can reuse it. Otherwise, you may need to take a whole new graft. So that'd be a tricky situation. I'm not an expert on that by any means. I haven't had enough to be able to tell you.
I haven't seen any of those either, and I think, I haven't seen any of those. I mean, it's for a good reason. Should be happening.
I've seen one in my career, and it was because of a fixation of a little bit of a posterior wall blowout, which is the danger of when you do a type of patellar tendon.
So we've got some questions here that we posted on IG story. We'll try to go through these as fast as possible. I know we've been going for a while. Some of them we've already talked about, so I'm going to skip some things. But let's say this. 4 months post-op ACL, is knee clicking normal?
Yeah, so I get the question about clicking a lot. If clicking is pain-free, it's generally normal. Usually after any type of surgery or even an injury, when the knee clicks or makes any type of sound, it could be because of scar tissue, fluid. You could have cartilage issues. So the truth is you shouldn't worry about the clicking as much. You should worry more about the pain. Yeah. Or the loss of motion.
Loss of motion, correct. So let's say this is from another person. Open chain quad exercise, when, how, and why not? What's your stance?
I'm going to let you answer that one first, and I'll tell you my stance.
Okay. So for me, there have been so many studies that look at open chain knee extension and the amount of ACL, the amount of tension in translation you put on the ACL, and then in comparison to walking downstairs, and it's pretty similar. I don't have someone bang out 1,000 open knee extensions week one, but I'm also not scared of having them start that with BFR where there's no weight on their limb and they're just going through knee extension, because that's what they do in gait. That's what they do when they go downstairs anyways. I don't load it up heavy till 12 weeks, like heavy. I'm not talking like max weight, but when they're doing BFR, it's super, super light weights on the ankle. And I start pretty early on when I do open chain knee extension.
Yeah, I think when you talk about doing it with that kind of lightweight and stuff like that, I think most people would agree that open chain early on is not a big deal. I usually tell them 6 weeks.
6 weeks, okay.
Yeah, so start working on the closed chain first and then start open chain in 6 weeks.
Okay, 6 weeks. Awesome. Question here on BFR for ACL rehab. How soon after surgery will you implement it? So for me, I implement that day one as long as there's no contraindications to BFR training as a whole. And I think what's super sexy with BFR is, so BFR for people that don't know is you're putting a pneumatic cuff on the limb. So if we're talking about ACL, we're putting it right on the inguinal area, so on the hip area. You're limiting the amount of arterial blood flow to the limb. You're restricting all venous blood flow back. BFRT is blood flow restriction training, meaning that's putting a cuff on and doing exercises with it. That is a higher entry level that's what most people think of when they think of BFR, but there's a lot of uses for BFR without actual exercise. Things like cell swelling or intermittent pneumatic compression, which is just putting the cuff on. So I start there with patients. And there's actually a lot of good studies that just putting the cuff on. There were some ACL studies. They did it, I don't know if you're aware, day 3 to day 14. So you pump up the cuff to 100% LOP, which means you limit all blood flow. You do it for 5 minutes, and you take it off for 5 minutes. You do 5 rounds of that 2 times a day, and they had way less quad loss in comparison to other sides. So I start people with that. Make sure swelling is managed. If swelling's not managed, I'm not going to put a cuff on them. Make sure all the other things that you would do in rehab are taken care of, and then you can start implementing BFR. That's my stance. I don't, do you guys use BFR?
So I have, so it depends where my patients are getting their therapy. I have some patients that do get it. Now I'm okay with it. I'm very excited about the future of it. I've seen some articles. The problem is at this stage to make any type of, true medical opinion with this limited data is just too difficult, but I'm really excited about the future of it. And I think that the idea behind it makes a lot of sense, and oxygenation and all that. So.
Yeah. There were a lot of BFR questions that I'll just use that answer as hopefully all of them. A lot of graft option questions here. I'm just going through them. Oh, how do you deal with the cyclops lesion and that's impeding recovery? That's a good one.
That's a little bit confusing. So why do they have a cyclops lesion? You're talking post-ACL reconstruction?
Post-ACL. We're talking post-ACL. How do you deal with the cyclops lesion? Let's talk about what a cyclops lesion is.
So, cyclops lesion is usually what ends up happening is a part of the torn ACL is kind of flipped and it blocks your extension. It shouldn't be there post-ACL reconstruction generally. If it is, there maybe some of the remnant wasn't taken. So I'm not so sure about that. Or sometimes I have seen some patients in allografts where they have their ACL reconstruction over time. They have like a partial tear and they develop almost like a cyclops lesion. Mm-hmm. But generally, I don't see it early on ever.
Yeah, I've seen one. It was later on.
Yeah, exactly.
He had normal range, and all of a sudden he just had an extension block and pain, and then got and then cyclops lesion cleaned it out, and he was good to go.
Exactly. So if there's a cyclops lesion late, that's exactly what you do. If there's an extension block and pain, etc., you go ahead and take it out. You debride it as long as that ACL graft is intact, but you got to make sure that graft is intact.
Yeah. We have a question here. This is a very general question. It's going to depend, but how long does it take for anterior pain to go away with kneeling? I'm assuming this person had a patellar bone.
Yeah. So it's a really, really good question, and it's so hard. It's such a case by case answer. I've had patients that have even done a revision ACL on 21-year-old athlete done a revision ACL, taken their patellar tendon before they had something else, and they've had zero knee pain. They never complain about it. So it's so interesting. And I have patients, a handful of patients that come in, and they always complain about this, especially the kneeling pain. So it's variable. It depends on you, depends on your pain tolerance. One of the things that I do to try to help it is I move my incision medially. It was how I was taught. So I'm bringing it a little bit more away from the tibial crest. So you imagine this big crest right here. I move it a little bit more medial. It's not directly over that. So sometimes I feel like that helps with the kneeling pain and the anterior knee pain. And And besides that, actually, I don't have a great answer.
I know for me in rehab, when I have people with it, it's building up their tolerance to those positions, just like we would with anyone else in pain, regardless of the ACL, regardless of the graft. You have to, so there, yeah, you can work on the soft tissues around it. You can work on patellar mobs. You can work on scraping and all those other things to the tissue itself. But when it comes to pain, just getting them used to those things. Okay, let's do 3 minutes at a time, 10 times a day. And you're going to nail up to your tolerance, and you're just working up slowly that way. Is usually what I do, and it takes a while, and it sucks, but that's part of desensitizing tissues and getting yourself used to that stretch.
Absolutely.
Let's wrap this up in a couple minutes. I'm going to go through a couple. Let's do this. Let's do a quick summary of what we've gone over. Any last closing points that you want to make, and then we'll call it.
Yeah, so one of the things is, especially when we're talking about patients throughout the country, depending on where you're located, you may it can vary what you have, what kind of access you have to a sports-trained, fellowship-trained orthopedic surgeon. So you may go to someone, for example, that only does a hamstring, and you may be a 20-year-old athlete who wants a patellar tendon, for example. I think it's really, really important to remember a couple things. If you want a certain graft because you feel like that graft fits you best, you need to make sure that you either find a surgeon that can do that graft comfortably, or something to always keep in mind is all three of these are great graft options. So if the best access you have is to someone who's doing 90-95% hamstring or 95% quad and very little patellar tendon, it may be best to take that other tendon, that what they're doing 90-95% of, instead of trying to force your surgeon to do something that may fit you best. Yeah. Or find someone that is going to do the graft that you like and does it often. Surgeon comfortability is also as important as what you want and what you want done. So, do your research, talk to your doctor, find out what type of grafts that they like to do, what they feel comfortable with, what they feel like is best for you, and what you feel like is best for you. Read about it, be educated. I think patients nowadays with the internet are always so educated. It's very refreshing to see. Besides that, my other comment is, always remember, social media is a little bit dangerous. You guys oftentimes have so many questions about, well, someone did this, did they do this wrong or whatnot? None of us, Mike, therapists, athletic trainers, he's a surgeon, your other physicians, we cannot replace the person who has their hands on you. You got to give your confidence to that person, whatever field they're in, because they may see things that you're not able to truly relate to me that is going on in your case. And I can give you an answer that's incorrect. So it's not fair to them, or fair to any doctor, or fair to any therapist or trainer for us to second guess them. So when we give you information, it's always general information, and it's never to second guess a doctor. It's information to help you go back to your doctor and say, these are some of the things I've read. What do you think about this? Am I a candidate for this? Talk to your therapist. Can I do this early on? Can I try BFR? Always trust the person you're with, because that builds a great relationship, and they always have your best interests in mind in that situation.
Yep. And the big thing is, when you're on social media, you're providing education, not advice. Very, very different. You're providing education and generally talking about topics, but the advice is going to need to come from someone that knows you, that you've seen in person, that feels you, has your imaging, sees all little things that we're not going to see. We're not even at a space or an area where we should be able to give advice on those things. Legally even. So
legally, and more importantly, remember, we're getting a history from you. We don't get the complete picture, no imaging, no physical exams. So truly trust those people and give them your faith. I know there's a lot of really good people out there that want to go out of their way for you.
Yeah, let's end it with that. I hope you guys really enjoyed this talk. I know I did. Learned a ton. Always learn so much every time we talk. Nima, this was awesome. If you guys have certain topics that you guys want to hear about, let us know, because we want to do this more. Just, send us a DM, send us an email. Our goal, both of our goals is to educate as many people as we can, and make sure people are as informed as they can when they have to do these. These are life decisions. These are really our life decisions. You want to be as well informed, knowing A, what you're getting into, and B, what the other options that you have. We live in a day and age now where we have information at our fingertips, and it's about getting the right information and then making an informed decision. Hopefully we're able to help people out.
Yeah, and also, thank you all out there, because we learn a lot from you and your experiences.
Oh yeah.
So we're learning in the process every day, and anybody that you're seeing, whatever medical professional you're seeing, they're learning from you, and we're grateful for that.
Yep. Awesome. Let's end it here. Thank you guys for joining in. We'll see you.
All right, take care, everyone.
Thank you for listening to this podcast with Dr. Nima Mehran, an orthopedic surgeon here in Los Angeles and a really good friend and supporter of ours. Please go follow him on social media at Dr. Nima Mehran. And if you guys like this, please rate, comment, and review. The reviews mean a ton for us. They really, really help us with the rankings in iTunes and Stitcher. We want to do way more of these with every single orthopedic surgery you can think of, speaking with the people that do them and know them the best, orthopedic surgeons. So please drop us a line, drop us a review. If you have any questions, please reach out to us. Thank you.